meningitis and ventriculitis are very challenging for us who work in the neurocritical care unit to manage these patients. And we have in our institute, we have a team of workers, intensivists, the consultant intensivists, and also the microbiologists helping us how to address these nosocomial infections. So, what is nosocomial infection? The WHO defines nosocomial infection as a hospital acquired infection. The patient comes with no infection, and after some some therapy or some like EBD and all this, and the patient gets infection. So this is nosocomial infection, and the infection, so it is not present at the time of admission and acquired during the hospital stay, maybe through healthcare facility like or the healthcare associated healthcare infection. So new infection of meninges acquired during hospitalization, usually manifesting after 48 hours, is nosocomial, often associated with neurosurgical interventions. What I said, that CSF drainage procedure and shunt is fever, headache, and change in the mental status. How will you recognize that? And the neurological status at the usual presentations. And if you go for investigation, there will be CSF pleocytosis, biochemical abnormalities, and abnormal blood counts. The types we encounter is bacterial, viral, fungal, parasitic, and chemical. They are rare, and bacterial is 40%, but associated with mortality, morbidity. Viral with herpes simplex we can get, and the incidence is shunt infection is 4.17%, EBD related 3.18%, and lumbar drain related 0 to 5%. The incidence is low, but if it happens, it will just make you so uncomfortable, and you cannot also avoid morbidity, mortality here. So, mostly gram-positive cocci are consistent 50 to 60%, and most common is the coagulase negative staphylococcus. But nowadays we are getting gram-negative organism rising, and the incidence, recent incidence in 22, it was 58%. And the bacteria the organisms are Acinetobacter, E. coli, Klebsiella, Pseudomonas, Staphylococcus, and Serratia. My microbiologist will again give you the report what we have in our institute. So what are the risk factors? Invasive procedures, as we have said, craniotomies after operation like T1 neurosurgery and placement of EVD, ventricular catheter, LP, lumbar puncture, spinal anesthesia, and giving drugs, intrathecal drug delivery, antibiotics or chemotherapy like that, we may land up with meningitis. TBI, subarachnoid hemorrhage, spinal injury, polytrauma, and with head injury, they will also come with this infection. Patient with road traffic accident without any infection come to your ITU, and after within 48 hours you get the infection. So metastatic infections from bacteremia. The patient is having bacteremia and then gets the CNS infection. Older age, immunocompromised, as we have many patients, diabetic patients, many transplant patients with immunosuppression, all these patients, they are more prone to this hospital acquired infection. And patients with comorbidities, what I said. A 10-year retrospective study from April 2010 to March 2020 by Sophia et al. They have they studied, and it was also published in the Critical Care February 2022. They have included 70 patients, and the incidence of nosocomial meningitis was 0.75%. 22% were immunocompromised. Predisposing factors were TBI, skull base fracture, and brain hemorrhage, CNS invasive procedures, as I have said, the devices, they are found. This is very important. 93% of their patients were associated with CNS invasive procedures like EVD drain or shunt. So, and 27% were bacterial, and gram negative is more than gram positive. They found that. Complications developed in 47% of patients, and advanced age more than 65, complications associated with high mortality if the age is more. So our INK statistics, I have seen it from the whole year of 22-23, the total CSF culture was 370, and positive samples were 13. And the bacteria are Klebsiella, E. coli, Staph aureus, coagulase negative staph, Proteus, Serratia. And fungal we had 2. But Dr. Mohana will give you, after I finish, she will give you the present statistics and what are the organisms in detail. So it is the most important that when you suspect nosocomial meningitis, you have to react. What are the suspicions? Like acute onset intense headache, plus minus vomiting and nausea, alter or worsening mental status, the GCS is going low, and by 2 in every 1 hour you are monitoring the GCS, and the GCS is going low by 2. So then additional signs of meningism like neck stiffness, temperature rise and all this, and there is fever, new rash. It is also plus minus new rash. It is an indication of the patient is having CNS infection. New onset seizure, which we often have. Pediatric patients, fever, hypothermia, patient is lethargic, irritability, poor feeding and vomiting, all these things in pediatric cases you suspect for nosocomial meningitis or encephalitis. And the background has to be neurosurgery or traumatic brain injury, traumatic spinal injury, procedures like CSF shunt, EVD and LP. So you have to see together what is happening there. And the approach to suspected nosocomial in ENLS guidelines, it is the emergency neurological life support guidelines by NCS. They have given that step 1 is resuscitation, start empiric antibiotic, IV access and fluids to treat the shock, antibiotics for bacterial meningitis plus minus dexamethasone. Here I will stress upon that antibiotics, you should also consider what is the antibiotic you give in your hospital setup. That your microbiologist will tell you to start which one. So that is one thing. Step 2, you have a head CT if it is required in cases of TBI and intracranial hematoma. Step 3 is the lumbar puncture. It is the gold standard to guide you what therapy you are going to give. So if CT results are available, you may not go for lumbar puncture, but sometimes you go for lumbar puncture and it is the definitive thing. Before lumbar puncture you will have CT, or after lumbar puncture you go for CT. So this is the early antibiotic decision. I am not going to emphasize here because my colleague Dr. Orijit will give you. But it is empirically, you give whatever your institute is having, and it is usually the third generation cephalosporin we use, or meropenem or plus vancomycin. So indication of imaging. Imaging is not important in these cases. You go for LP, and indication of imaging, if the patient is more than 60 years and history of CNS disease is there, and immunocompromised status, history of seizure with 1 week of presentation, abnormal neurological status, impaired consciousness, abnormal speech, cranial nerve dysfunction, and motor findings, along with papilledema. If you have this, you go for CT scanning. And LP is the gold standard. Collect the samples in 4 tubes, 1 and 4 for RBC, WBC and DC. Second is for protein, glucose and lactate. Third is for gram stain, culture sensitivity, antigen PCR for virus, tuberculosis or fungus. And these are the things which will be again emphasized by Dr. Arijit. Very high WBC count, bacterial meningitis. High WBC, no RBC, you suspect viral infection. High WBC and high RBC, there might be associated herpes simplex. You go for CT, you will get the typical finding there. High WBC, very high protein, fungal and TBM. High RBC plus xanthochromia, so subarachnoid hemorrhage is suspected. Lab findings, you can have elevated lactate, procalcitonin and lysozyme. This helps in early diagnosis. Presence of oligoclonal bands, IMG and IMM bands, cerebral pleocytosis, more than 10 cells per microliter, and more than 50% are polymorphs. CSF glucose will be low, less than 25 milligram per deciliter. Positive culture is confirmatory. Sensitive antimicrobial therapy helps in the prognosis. So you can prevent mortality and morbidity. Preventive measures and pharmacotherapy are the management of treatment. How to avoid device related infection? We have seen that it is the most common one. So you should be very cautious to avoid device related infections. So insertion technique should be very aseptic, and duration of catheterization should not be very long. Presence of intraventricular hemorrhage, you identify and treat that. Lack of infection control bundles, that is why we are getting this. So you must institute infection control bundle by your microbiologist. Prophylaxis, sterile placement, what we have done. Antibiotic at the time of device insertion, you should give that. External catheter should not be kept more than 5 days. Antimicrobial impregnated catheter may be used to avoid infection. Nowadays people are using that. So EVD, you have to have insertion bundle, maintenance bundle, avoid irrigation. We sometimes irrigate the EVD, and unless intraventricular drug is given, if you are going to administer cholesterol, so you can give in that time, but otherwise you should not irrigate or that catheter. Closed system maintenance is ideal, and nurses should be trained how to handle EVD. How to handle EVD, nurses have to be trained, and remove it as soon as possible. So these are the IDSA recommendation in 2017, and after that there has been no recommendation coming out. I am not going to in details because my colleague Dr. Arijit will address this. এখন বলবে না এখন বলে দেবে এটা একটু এগুলো সরিয়ে দিচ্ছি
Okay, very good afternoon. Ma'am has described all the things. I want to add something. First of all, in nosocomial infection বা nosocomial meningitis, we have to do the CSF study first. And every time in the postoperative period, patient has already received antibiotics. So culture reports sometimes comes negative, but it doesn't mean that patient has no infection. So we need CSF lactate report. If the CSF lactate is more than 4 millimole per liter, then we have to start antibiotic and should consider this case as a nosocomial meningitis. Means CSF glucose and CSF lactate, which has most importance. I think CSF lactate has the most important value than the CSF glucose. So IDSA recommendations 2017 empirical antibiotics. Vancomycin plus anti-pseudomonal beta-lactam is recommended as empirical therapy for healthcare associated ventriculitis and meningitis. Anaphylaxis to beta-lactam antimicrobial agents, and in whom meropenem is contraindicated, aztreonam is recommended for gram-negative coverage. And vancomycin through concentration should be maintained at 15 to 20 microgram per ml. One thing means what should be the empirical antibiotic therapy in case of nosocomial meningitis? It depends on the antibiogram of your institute. It not depends on the antibiogram of different institute, because you have to start the antibiotic of the causative organism according to the antibiogram of your institute. So sometimes in our institute generally we do the means either through EVD or through the lumbar drain. So we generally give 10 mg intrathecal colistin and we get the result. So in MRSA the specific antibiotics is vancomycin. Alternatives to vancomycin is linezolid, daptomycin and cotrimoxazole. Device associated staph aureus, rifampicin can be added if sensitive. In multi-drug resistant pseudomonas, meropenem alternatives and aztreonam and quinolones can be added. In gram-negative bacilli susceptible to third generation cephalosporin, ceftriaxone or cefotaxime is recommended. So in case of Acinetobacter, the IDSA guidelines is meropenem, but in our institute we generally add colistin, mainly intrathecal colistin. And in XDR, IV plus intraventricular colistin and polymyxin is highly recommended for treatment of infection caused by Candida species based on in vitro susceptibility testing. Liposomal amphotericin B often combined with flucytosine and is recommended. For treatment of infection caused by Aspergillus species, voriconazole is recommended. Thank you.
Thank you, Arijit, for that. So I'll request Dr. Parijat to give, then I'll have some case discussions. Dr. Parijat is the consultant intensivist in my institute, and এটাকে মিনিমাইজ করে দাও তাহলে না আমি পরে পরে বলবি কিন্তু পরে পরে আবার ওখানে আসতে হবে। আসা যাবে তো?
আসা যাবে না, এইচডিএমআই লাগানো যাবে।
আসা যাবে না? তাহলে তাহলে পরে ও বলুক না। So let us come to some of two cases I'll show you that we have this multi-drug resistance. This case is a 45-year female, hypertensive, diabetic with massive left basal ganglia bleed, admitted to our emergency through our emergency on 14/8/2022. On admission, there was bilateral infiltration on her chest X-ray. So we started piperacillin tazobactam and was later upgraded as it did not respond to meropenem and doxycycline. Then unfortunately she started having fever on 3rd of September, became drowsy. Immediately the CSF study was done and the CSF showed cell count of 10,500, protein 850, lactate 24.9 and her CRP raised to 308. So meningitis dose of meropenem and vancomycin started. Pus culture from the surgical site revealed Klebsiella, and as her condition was not improving and high suspicion of GNB, vancomycin was stopped and the intraventricular colistin, as Dr. Origi said, was added. This is the patient as he is on 16th of February 2023. She is at home now. So the Carva CSF showed Klebsiella resistant to BIM, NDM, KPC, Oxa, and antibiotics changed to aztreonam and 2 gram IV TDS, colistin 4.5 mu IV BD. Patient clinically improved, and CSF on 13th of September, lactate came down, cells also came down, protein 462, decannulated and discharged on 27 September, and this is the picture in February. So she is doing well. Another case, 49-year-old male, admitted on 7th of February 2023 with CSF leak from craniotomy done on 9th of November 2022. The wound suturing done on 8 February 2023. Following day, he developed fever and became drowsy. Blood and CSF sent to lab. CRP was 107.9. Total count was 6,300. Sodium 158. Potassium 2.7. So he has been on the CSF culture showed serratia sensitive to meropenem. So we started meropenem. He was on vancomycin, switched over to meropenem. This is the patient as on 17th of February. He was, you can see, he is eating, he is well and eating, and measures of hypernatremia and hypokalemia were taken. And on 14th of February, sodium was 147, potassium 3.2, CRP 34.8, and the patient was conscious, vitals were stable, and he was ambulatory, started physiotherapy. So if you identify and treat immediately, then the patients are okay and you can make them. So in my conclusion, I should say nosocomial meningitis is a medical emergency and requires early diagnosis and prompt management in neuro ICU setup. Though the incidence is low, it is associated with high mortality morbidity as the organisms are often multi-drug resistant. And CSF analysis, early empirical antibiotic along with steroid are the mainstay of management. Adherence to infection control bundles can prevent this life-threatening condition. So thank you. This is my team, and I'll request our microbiologist. She can throw some light what is our incidence after she joined after 2022, and she will give you. Dr. Mohana, my colleague, microbiologist.
Thank you, madam. So it's been just 6 months I have joined INK. So since then, I have been tracking the number of rate of our nosocomial meningitis. The rate of prevalence is almost 11%, means 1 in 17. It's positive, and the organisms, it has changed. Organism, it's although it is Acinetobacter is at the top, but we also have Streptococcus agalactiae, and recently we have got a case, old operated craniotomy, and patient got readmitted with a empyema, and it was detected Streptococcus agalactiae, and we have Enterobacter, and we have Proteus. So this was a kind of concern for me, because these all are gut commensals, gut flora, Enterobacter and getting Proteus in the culture, which are multi-drug resistant. From where it is coming? So I did a surveillance. So there was a lack in the nursing, from the nursing point of view, because somewhere maybe while giving patient the body wipes and everything, the EVD is getting touched. There maybe it is getting contaminated with it, and if the EVD is kept for more than 5 days, uh, maybe there is a cross contamination. So what I introduced quaternary ammonium chloride based component that is used as a wipe, with which is a fifth generation quaternary ammonium chloride compound. So it can clean the EVD up to 99%. So I have done a pre and post swab. So the EVD, regular daily taking care of the EVD, and if there is a lumbar drain, those can be wiped off with that. And coming to the antimicrobial point of view, nowadays, although ma'am has covered, and Dr. Arijit has also covered the antimicrobial usage as per the IDS guideline. What I would like to add to that nowadays BLBLI composition, most of the Acinetobacters which are causing nosocomial meningitis, ampicillin sulbactam is coming into the into our knowledge, and there are many papers which are getting uh, published. Along with that, people are using sulbactam in a very high dose in case of Acinetobacter. Thinking of it, uh, although it was surprising in the beginning for me why people are using sulbactam, beta-lactamase inhibitor, without using a beta-lactam. It is because they are thinking maybe patient was already on, not maybe, because when the patient gets admitted in a tertiary care hospital, they get a broad spectrum antibiotic which already has a beta-lactam ring in it. So
What you were.
okay. So we have, I think Dr. Arijit only you had used for one patient high dose sulbactam. So that patient recovered. The patient recovered, and he is doing well right now. And another thing, in while doing the EVD and in any invasive procedure like craniotomy or anything, I must talk about the SUDs, the perforators. The perforators which I have changed in our policy, that perforators should not be reused. It should be single-use device always. That's all, ma'am. That's all I could have done until now. Thank
Thank
you.
you, Mona. And I'll request Dr. Parijat to give the overall up to till now, what is our nosocomial rate there. Then I will request our colleagues, Dr. Raha and Dr. Chakraborty to say also something. Parijat.
থেকে একটু এবার ইয়ে করে দিবেন আপনার হয়ে গেছে তো?
Hmm.
হ্যাঁ First of all, good morning, everyone. So actually, this was my poster presentation in the morning. So for here only just to look these two tables. So in our hospital, these are the data from March 2023 up till January 2024. So during that period, the total number of surgeries were 22 around 2200. So which included all those endovascular surgeries and others. So among them, the cranial and spinal surgery, it was done. So this cranial surgery was 1300 plus and spinal surgery was 360. So among them, only 22 patients were post-operative central nervous system infection was. So in cranial surgery, we found that the pattern of organism was most of them was MDR strain, and this infected shunts and all these drains we had already removed, and all the surgeries were on emergency basis because of this decompressive craniotomy has to be done to reduce this ICP, and that is what. And in case of spinal surgery, that was there was total number of infection was 10 and the implant used 7, and the pattern is Klebsiella and only one was MDR case, and both the cases in the cervical spinal surgery, both the patients they succumbed to death. So this is my so just only two things I just want to add on this thing, that only two things we have to be very careful. Just in picking up the infection, the index of suspicion in cases of the postcranial patients, we have to be very high. Even a slighter alteration in the sensorium level, it shouldn't be missed out, because they cannot, this patient, this cranial surgery patient and all, they cannot mount all time all those the symptoms and all, because they are most of the time they are drowsy. So that is one thing. And second thing is that the antibiotic penetration it is not, we are not sure, it is not clearly demonstrated that how because of this CSF, our physiological barrier and all CSF brain barrier, it is not evenly distributed. So that is why while using, and the duration of the antibiotic is, it has to be extended, and that is what. Thank you, ma'am.
Thank you, Parijat, for that excellent. And she has already again emphasized on MDR resistant, multi-drug resistant organisms, and you have to hit hard all the time. Identify and hit hard. Always it is not that these patients will show that there is signs of meningism and all these things, but your sensorium. Here I will also emphasize that if the patient is sedated, patients are on ventilator, and you are giving sedatives, analgesics, so you cannot monitor the GCS actually. So other things, hemodynamically, how the patient is stable, and the temperature. Temperature management is very important in these cases. So targeted temperature management, all these things have to be done. And epilepsy, if the patient seizures, you can also, if the patient is on anticonvulsants before, you cannot also identify that. So all these things, it is observation, observation and observation. All the time you have to observe the things. And what Dr. Mona emphasized, that you train your nursing staff how to handle the devices. What is, she has already said that these are the newer anti-infective things coming up, and we can use that. So that is one thing. I'll just request my colleagues, Dr. Raha and Dr. Chakraborty, what is your experience there? Dr. Parijat already said the
Uh, my personal experience in the institute I'm working in IMK is we have a high incidence of device-related meningitis, and that shows that either there is a problem in the insertion bundle or the maintenance bundle. So and the organisms that we isolated usually from these device-related antibiotics, they are gram-negative organisms and very resistant to all antibiotics. Most of them are MDR or XDR organisms. So prevention is better than cure in this case, and strict maintenance of insertion as well as a maintenance bundle is very essential to prevent such nosocomial infections. That's it. Thank you.
Wonderful presentation by all my colleagues. I would just try to emphasize a couple of points which my colleagues have already mentioned. Uh, Number one is, as we discussed till now, the incidence of nosocomial meningitis does increase when there is a breach in the meninges. And as we know that putting in devices like ventricular drains also does increase the incidence. Among them, putting in the like VP shunt, that is internal devices, have a much more incidence than putting in external devices. And if you are like putting lumbar drains or like lumbar puncture, the incidence decreases further. So it's mainly when the brain CSF is involved or there is a breach in the brain CSF that the incidence of nosocomial meningitis increases a lot. And again, my friends also emphasized one thing, that it is not like normal meningitis as such, because the clinical signs and symptoms are quite less and very difficult to pick up. And so we have to be very vigilant, and we have to be really assess from the beginning that, well, this person can develop nosocomial meningitis. Person having a base of skull fracture, person having a ear infection, a person having a depressed skull fracture, person having an EVD or a ventricular peritoneal shunt being placed. All these patients, when the GCS is decreasing, patient is getting septic, definitely we have to think about nosocomial meningitis. More so when we were talking about the CSF studies, the CSF culture are quite, means positive culture is quite less. So that itself is also a drawback. And as Dr. Barui said, that CSF lactate more than 4 is more of a certain investigation to say it's nosocomial meningitis. More so, there are few studies that have come up where they are testing CSF procalcitonin along with CSF lactate, and the positive predictive value as well as the negative predictive value has come out to be very good. So that also is an option. We are also doing viral PCRs and things. So there are a lot of further investigations that are coming up as well. But yes, it all comes upon the clinical decision and the suspicion, because as I said, means you can't rely upon the CSF leukocytosis. You cannot rely upon the culture. Means culture are negative in most of the cases. So you have to have a very high suspicion to think about nosocomial meningitis. More so regarding the microbiology, as Dr. Mohana said, means mainly previously it was Staph aureus and the coagulous negative staph, which were very more prevalent. But as we see with the decreasing infection control practices around our country, the Escherichia group of bacteria are also coming into prevalence, and that we also have to be a bit careful about. So yes, and as we know that with the guidelines, the vancomycin along with cefepime or ceftazidime avibactam or meropenem in the meningitis dose does suffice as
It's okay, then it is okay. And another thing is that what he said, blood-brain barrier is disrupted. So if you are giving in something IV, it may not work. So you can give intrathecal things. You can try that. That is my view. Whatever the other people can.
Yeah. Good morning, doctor. So just one thing I want to add, because these patients are long-standing, they are chronically, for a long period they are bedbound. So in that case, you can rule out this thrombus, any kind of DVT and any kind of things are there, because if any small thrombi, it can cause also fever. So
they must be doing that.
yeah. So
Prophylaxis,
DVT prophylaxis and all, yeah. So, and you can radiologically also you can rule it out. So, quite a time we get the very good result.
Good afternoon. Have you checked the CSF lactate at that patient? Less than 2. Okay. We have many patients, neurological patients has central fever, especially in ICH, brainstem blade, or in many patients can have. So you can add bromocriptine, you can add beta blocker, you can add baclofen if there is no history of previous seizure, and you can add also nimodipine as a treatment of central fever. Okay. Thank you. This is central fever, ma'am. If there is no other culture, all the cultures are negative, and the CSF lactate is just 2, so we can treat the patient as central fever with this type of things, bromocriptine and nimodipine and baclofen. Yes, ma'am. Evidence of central fever. Yes, if the all the cultures are negative, means this is the last diagnosis.
kinds of therapy, you should also rule out everything, because sometimes only reactionary fever after the surgery the patient may have, and all the things are go for a holiday and see what is happening. Okay. Okay. Any clarification? Anything? So thank you, my team. And oh, you wanted to say something?
কলকাতায় হচ্ছে তাই
Should we